Hello everyone. Now I'll discuss question of neurology. Well, we have a 68-year-old patient hospitalized and he had to be evaluated for new onset leg weakness. 6 days ago, he was admitted to the hospital due to fever, right leg pain and swelling. Physical examination showed right lower limb extremity edema, warmth and tenderness from the foot to the mid calf. Definitely the signs of inflammation are there. TLC count is very high and venous Doppler ultrasonography revealed leg veins without any thrombosis. Oh, one of the important DD was deep vein thrombosis which have been ruled out. Culture grew Staph aureus, that means infective pathology is there. Patient was treated with intravenous antibiotic, leg symptom improved. However, this morning he had trouble getting out of bed due to significant leg weakness. So he has a problem since today morning. Well, in addition, past history of hypertension, type 2 diabetes, coronary artery disease, systolic heart failure, chronic low backache from work-related injury. Patient had worsening mid back pain over the last 2 days. Temperature is again high, BP is normal, and mental status normal, cranial now normal. Abdominal examination reveals a suprapubic mass, midline tenderness over the lower thoracic vertebrae is there. Upper extremity strength is normal, but he is not able to lift either of the lower extremity against gravity. Well, what is the next best step in the management of this patient? Well, answer this question is MRI of the spine. Why this the answer? This case seemed to be a case of epidural abscess, spinal epidural abscess, what we write as SEA. It's a rare infection, not a common infection of the epidural space that may threaten the spinal cord and it can result in much of the disability also, especially spinal cord related if not taken care in proper time. Most cases are due to hematological spread from a distance in infectum source of infection, like cellulitis, bone marrow, like in this pain, bone or joint, like in this case, patient has a leg infection and finally it must have reached the spinal cord or maybe venous drug abuser. Why? Okay. Staph aureus is the most important organism and we are well aware that it is in intravenous drug abuser also in cellulitis. All these are commonly caused by Staphylococcus aureus. Okay. Well, when we talk about spinal epidural abscess, classically result in triad of fever, back pain and neurological deficit. Like in this case, there is all three are there. Fever is there, back pain and paraplegia is there. But all these symptoms together may be there in all, not in all the cases, only in minority of the cases. But in our case, all these features are there. Most patients initially develop severe localized back pain that progress over days to nerve and that may going to compress the nerve. Shooting pain are there. Like in our case also, patient has that back pain for a long time. And later on severe some problem of the neurology, like in our case, motor weakness is there. Patient has got paraplegia. They again indicate late stage and there is a bladder dysfunction can be there. Is it there in our case? Let us analyze. So we are making a diagnosis. The option is SEA, spinal epidural abscess due to high sensitivity early in the course of illness and external localization of the infection extent is there. Treatment with broad spectrum antibiotic, aspiration and surgical decompression, especially when the compression symptoms are too much. Okay. So we have to localize the problem by doing MRI So now you are convinced that why that option is correct. Now let's look into other option, nerve conduction studies. This we do especially whenever some peripheral nervous system is involved, like entrapment syndrome or polyneuropathy, especially GBS, Guillain-Barré syndrome, or any nervous problem. Our patient has bilateral weakness, fever, spine tenderness, and known case of Staph aureus bacteremia, because in blood culture we already have grown Staph aureus. So Staph aureus problem is there. So definitely it is not a case of polyneuropathy. So this study has no value in this case. CT scan of the abdomen. Suprapubic mass is a distended bladder. In fact, okay, and it has nothing to do with any other mass. One more thing, golden rule to remember: if you are in a male patient, if we are getting a suprapubic mass, first possibility is always full bladder. It is essential. And how you can do clinical examination? You do percussion. You get dull on percussion. Dull on percussion. Of course, in females, the possibility of fetus is there, but as of now, I'm talking about male patient. Suprapubic mass, unless proved otherwise, is a full bladder. And you should always put a catheter to prove it. Patient may be having retention of urine due to whatever reason it may be. Put a catheter, the mass disappear, when the urine comes out, that means suprapubic mass was due to bladder. In this case also, before you do anything, just put the catheter, take out the urine, and that's why ultrasonography or CT, any abdominal imaging is not needed. Echocardiography, Staph aureus is the causative organism of bacterial endocarditis, especially in the setting of IV drug abuser. But the endocarditis patient have fever, which our patient has, skin findings, splintal hemorrhage, etc., which are not there in our patient. Pulmonary symptom may be there, and moreover the patient is very toxic, and they may have some murmurs. Changing character of the murmur can be there, which is not there. So it is unlikely, and moreover endocarditis patient will not have bilateral weakness of the lower limb. So this possibility ruled out automatically. Lumbar puncture we do for suspected meningitis. In meningitis we have fever, our patient has, but in meningitis classically they have more of a neck rigidity. They have photophobia. And usually this paraplegia is not a presenting feature of meningitis. So there is no point in doing a lumbar puncture in this case. No need to this thing. Now, so golden line to remember. Let me give you a summary of the spinal epidural abscess. Summary. Epidemiology, Staph aureus is in 60 to 65% cases. Inoculating source may be distance infection like cellulitis, spinal procedure or injection IV drug abuser. They are the source of infection. The triad is fever, back pain, and any of the neurological deficit. Raised ESR, blood culture, and MRI of the spine. Antibiotic, and you have to aspirate or you have to drain it surgically. Well, we can give vancomycin plus ceftriaxone are the drug of choice in this case. But now I have one more question for you. Stop the video, write down the answer. Tell me which anti-tubercle drug, the drug that we use to treat tuberculosis, has also anti-staphylococcal agent. Stop the video, write down the answer. Well, the answer is rifampicin. Rifampicin is an anti-tubercle drug but is effective against Staph aureus also. Okay. Thank you very much.